Let's now look at some of the clinical features we'd expect in liver cirrhosis. We are starting with ascites. When it comes to how ascites is happening, I want you to think of it in two ways. The first way is on the functions of the liver, and the second one is going to be with how blood is flowing towards and after the liver. Let's start by looking at the blood flow. We are starting with the GI. With the GI, blood is then flowing towards the liver. From the liver, blood is flowing to the inferior vena cava. From there, it is going to the heart. Now, in this case, we're dealing with liver cirrhosis. We're saying that there's irreversible scarring and fibrosis of the liver. It's led to some sort of compression of the sinusoids within the liver. It's hard for blood to flow in this direction. So because of that pathology, blood begins to flow backwards towards the GI. And if you can see over here, because of this backflow, we are basically increasing the pressure in this portal circulation. There is an increase in the portal pressure, or basically portal hypertension. And how do we define this? This is basically portal pressure greater than 5 millimeters of mercury. So whenever we're thinking about how fluids are within the body or fluid dynamics, I like to think of it like some sort of a seesaw. Homeostasis has to be achieved. On one end, we've got hydrostatic pressure, and on the other end, we've got oncotic pressure. Hydrostatic pressure is mainly regulated by the blood pressure or the amount of fluids in a given compartment. Whilst when we're dealing with oncotic pressure, we are dealing with proteins, and the protein that we are mainly interested in over here is albumin. So already we've seen how the portal pressure, the portal hypertension has basically led to an increase in the hydrostatic pressure. That was the first thing. The second thing I mentioned when we're dealing with ascites, think about it as the functions of the liver. Part of the functions of the liver is to produce albumin. But in this case, because of the distortion that's happening at the level of the liver, we're reducing the functions. Part of the function, production of albumin, we end up with reduced oncotic pressure. So what this seesaw ends up looking is something like this, where we've got hydrostatic pressure overcoming the oncotic pressure. If we were to look at it in terms of a blood vessel, think of it something like this. In one end, we've got hydrostatic pressure, and unfortunately, we have a reduced oncotic pressure. What ends up happening because of this is hydrostatic pressure can easily overcome oncotic pressure, and fluids begin to seep up into the third space. We have what is known as edema, or in this case we have what is known as ascites, which is shown in this image. So of course you look for the positive fluid thrill, the shifting downness, and so forth and so on. And remember, a complication whenever we're dealing with fluid stasis is going to be infection. So in this case, spontaneous bacterial peritonitis. Anyway, I like to think of fluid dynamics in this way because it makes it easier for really, regardless of the condition. So let's say a condition like nephrotic syndrome, there's proteinuria, there's loss of urine, there's loss of proteins in urine, so oncotic pressure reduces and fluids begin to seep up into the third space. And what do we see with patients with nephrotic syndrome? There's fluid overload, there's edema that's present. Similarly, with lupus nephritis, the rapidly progressing glomerulonephritis, where there's that proteinuria, loss of oncotic pressure, and edema. Similarly, again, kwashiorkor, reduced proteins. Reduced proteins means that hydrostatic pressure can easily overcome it. What do we end up seeing? Babies with kwashiorkor have that edema, they have that ascites that can be seen. Coming to heart failure, the heart is failing to pump, and so blood it's not pumping sufficiently, so blood is remaining in certain compartments. And remember, I said hydrostatic pressure, we're dealing with fluids or blood pressure or fluids in a given compartment. We end up increasing the hydrostatic pressure, which can easily overcome the oncotic pressure, and again we end up with what? Fluid overload. So that's on ascites. On to the next point.